This is Dr. Sargisian, and today we'll talk about adult respiratory diseases and disorders. And I would like to skip the childhood disorders as I talked in review. It will be very small portion, and I'd like for you to review those independently at this time. When we start talking about these diseases, we need to know signs and symptoms, and it's basically a review of your Bachelor's of Nursing programs, the materials from there, but just very quick review. Dyspnea, orthopnea, apnea, wheezing, and coughing, nasal discharge. These are the signs and symptoms you will see patients in primary care most of the time. And we know that in hospital, the signs and symptoms can become more and more dramatic. But in primary care, these diseases most of the time are very benign and self-limiting, hopefully. But again, when the acuity of the disease changes, certainly you have to be more prepared to treat more life-threatening disorders. Auscultation is important in diagnosing respiratory diseases, and you can go from assessing breathing quality and rates such as labored, unlabored, rate of tach apnea, and of course we'll know that this may represent rapid respirations. Rapid respirations per se may be related to other than respiratory diseases. However, this may result in hyperventilation and related respiratory alkalosis. So as you all know, that this is the basics of respiratory disease description. However, I included it here to show you that this may be also related to life-threatening consequences. When we auscultate the patient, and we can hear the different sounds and rhonchi, which are rattling sounds due to obstruction. Rales, also known as crackles, it comes from French râle, and crackles also may signify the pulmonary congestion and may have critical significance in your assessment as we're talking about respiratory diseases. In primary care, they may signify chronic condition. However, crackles are not a normal situation, even with for someone with history of respiratory diseases, and most of the time it may signify something other than purely respiratory conditions such as congestive heart failure. Wheezes are wheezing sounds, and to determine or to describe this correctly and know what wheeze is, you need to remember that wheeze is a musical sound. You can play a tune with wheezes, as bad as it sounds, but wheezes are musical sounds. They have a tone. They are not noises like rhonchi or rales. What you can do to diagnose: chest x-ray is golden standard and the beginning of the diagnosis for respiratory conditions. At the same time, it's very affordable diagnostic tool and can reveal many different respiratory disorders. Sputum culture is rather unorthodox diagnostic tool in primary care. However, it's quite often used in hospital setting. Of course, sputum culture may be used for diagnosis of tuberculosis. Tissue biopsy through bronchoscopy can be done, as well as arterial blood gases may reveal the metabolic state of the patient, and particularly in this case respiratory acidosis or alkalosis. Pulmonary function tests are very useful in diagnosing restrictive and obstructive disease. Diseases of upper respiratory tract are one of the most common conditions patients coming and seeking care and treatment, not only in the United States, probably in worldwide. And the more climate colder, the more diseases of upper respiratory tract may be observed. So most disorders of this type are not life-threatening, as bad as patient feels. Upper respiratory infection is not life-threatening. It's caused by rhinovirus, and respiratory disease, upper respiratory disease caused by rhinovirus or common cold virus, and the other name can be called as infectious rhinitis or common cold, or a viral upper respiratory infection. So most likely it's rhinovirus, but often other viruses such as adenovirus or influenza can cause it. But without focusing on the name of the organisms, there may be more than 100 different organisms that can cause, and this all leads to the fact that it's very hard to develop immunity. What happens? The organism will invade the mucosa and nasal mucosa, and leading to the nasal discharge and inflammation. Mucus production will increase, and shedding of epithelial cell will start. This is a first line of defense, increases the vulnerability to bacterial invasion. So this is bacterial superimposed invasions or infections, I would say, will occur when initial viral infection starts developing. Wet, cold, unsanitary condition can cause this, and URI can develop. The most common thing you need to know, and most important thing you need to know, that people will swear that of course this is cold, of course this is from the cold weather, of course this is from the fact that I got wet and I got under the rain and I got sick. So we need to know that the weather don't make you sick, truly. What happens, weather, especially in the case of upper respiratory infection, leads to the congestion of the people in closed spaces, either in their apartments, houses, workplaces, movie theaters. People spend or tend to spend less time outside. And in modern society, you would say it's really difficult to spend time outside anyway, but cold weather increases this, and so congested situation leads to upper respiratory infection. So how would you treat this? You will treat this with palliative measures. Palliative measures include rest, fluids, antipyretics, and analgesics, and antibiotics can be prescribed if a secondary infection occurred, and hopefully you don't have to deal with this. But again, upper respiratory infection, it's not a cause for antibiotic treatment, because most of the time it's a viral infection. So when we're talking about this, we can say it's common cold, acute rhinitis can be contrasted with allergic rhinitis, where we don't have a microorganism infection and it's a hay fever. In case of sinusitis, pharyngitis, and laryngitis, in this case, this may be an invader of a bacterial origin, and it may warrant the treatment by specific bacteria. In all the last three diseases, most likely patient will have facial pain in sinusitis, a sore throat in pharyngitis, laryngitis, and this also does not need to be treated by antibiotics immediately because this can have a viral origin. However, if the condition isn't resolving, it's possible to treat this with antibiotics. But again, URIs usually are not life-threatening, at least in the beginning, and usually the superimposed infections or sequela of this type of disease may cause the rather life-threatening situations, such as Streptococcus A laryngopharyngitis may result in valvular disease and of heart, and also be life-threatening, become life-threatening. But again, it's not the disease itself, it's sequela. Bronchi and lungs may be affected by invasive organism, and the rule of thumb is then you have to be more alert, you have to be more attentive, I would say. You have to be more providing more treatment to, more treatment is not the correct word, you have to be more alert to prevent life-threatening complications, and this is usually more severe. It can be superimposed or be a sequela of upper respiratory infection, or it can be it's having its own origin. Disease of bronchi and lungs and asthma is a allergic reaction. Basically, it's a hypersensitivity reaction that will lead to the bronchial constriction and spasm and will lead to difficulty breathing. When asthma occurs or asthma attack, wheezing sounds will occur, and dyspnea will happen. Severe episodes may require drastic measures and treatment. So how to deal with this? The best thing, the best intervention for asthma will be, as bad as it sounds or as difficult as it sounds, to remove the allergic factors, to remove the allergens and bronchodilator treatment. Juvenile asthma can be triggered by exercise, which the difference from adult asthma, usually exercise cannot be really a trigger of asthma. But again, in both cases, bronchodilators will be effective. Bronchitis, acute bronchitis, is most likely a sequela of URI. So URI sequela, it means you can determine that this is really a viral disease. Patient may have fever, tightness behind the sternum, substernal tightness, substernal chest pain, productive cough, productive yellow greenish sputum. And if some people, another fallacy is when someone is having productive yellowish green sputum, it's like even a healthcare providers who've been in the business for a long time would say, oh my goodness, this is bacterial, we need to throw antibiotics at you. In reality, most of the time, acute bronchitis, even with productive cough and sputum, is a viral infection. So antibiotic treatment truly will not be helping. And in this case, the palliative measures again will be helpful. And in some cases with acute bronchitis, the symptoms may last very long time, up to several weeks, but again, it's viral, it's not bacterial. Treatment again should be palliatives, and it's rest, increased fluid intake, palliative measures such as cough syrup or Tessalon drops. Cough syrups may be a cough syrup such as Hicodone with hydrocodone preparation, and may lead to addiction and development of dependence. So try to prescribe something like Tessalon pearls, which are very effective and will be very, very effective measure without creating dependence, without creating dizziness and sleepiness and all opiate related side effects or effects. Antipyretics, if patient is developing fever, analgesics, and again antibiotics here for secondary superimposed infections. So let's talk about influenza separately. Influenza is a viral disease and can start as an upper respiratory infection, and at the same time it's not a common cold. It may have symptoms of, in addition to symptoms of common cold or pharyngitis, it can have also GI symptoms such as nausea, vomiting, and diarrhea. So influenza can be caused by three different types of viruses. They are highly adaptive and constantly mutate. At least that's the common or current school of thought. And there are A, B, and C types of influenza virus. Type A influenza may have several subtypes, and it's the most common type of virus. Influenza can result in pandemics, epidemics, global pandemics, and H1N1 type of influenza that was colloquially described as a swine flu also started a pandemic in United States and Mexico and North America in general, in Canada in 2009. It was a rather dramatic increase of cases and even little outcomes of the disease. Type B influenza also can cause epidemics, but its type B is milder and type C is sporadic cases and local outbreaks. Type C is really also local outbreaks and never can lead to, or never led so far, a large epidemic. So the flu season in the US already starting, and again the reason it's becoming so rampant because of the congested living condition, because of less time spent outside, and transmission occurs with inhalation or contact of respiratory droplets. Most people will recover from influenza, but nevertheless it may account for significant number of hospitalization and even deaths. Negative outcomes, it's if someone has already immunocompromised status, pre-existing chronic diseases, and children, they all may have more significant consequences from the flu. The death also can be associated with dehydration or pneumonia, or secondary superimposed pneumonia on flu. So this is a viral disease that again spread by coughing, sneezing, droplet infection, and the influenza may have incubatory period 1 to 4 days, and the most contagious is patient after 1 day after onset and symptoms. And influenza usually it will last approximately 4 to 7 days in adults, and the children can be having longer time, but infection can be spread up to 6-7 days from onset of symptoms. So how to treat influenza? Again, palliative treatment, rest, analgesics, antipyretics, and antivirals such as Tamiflu. Tamiflu is a great drug. However, in adult, healthy, otherwise population, the average time of decrease of longevity of the duration of the illness is approximately 1 day. So for some of us, 1 day is nothing significant. For others, it's a great time to recover from illness, great time to gain from recovery from illness and get back to work. But again, traditional treatment may be very effective: rest, analgesic, antipyretics, and also I'd like to add good hydration. And by hydration, I don't mean IV intravenous hydration, but oral fluid intake can be making or breaking the outcome of this disease. So fluids, rest, antipyretics, if analgesic. Prevention is hand washing, avoiding crowding spaces, and vaccination. Again, effectiveness of the vaccine varies. It can be from 60 to 80%, and there is a chance that the vaccine even will not have the effectiveness for the certain strain which is popular or rampant that in flu period. So making a vaccine, it's really educated guess, and it's a prediction of which strain will be more popular or more prevalent that flu season. So again, to finish this discussion about influenza, it's also important to know that there is some linkage, as we talked before, to influenza vaccination and Guillain-Barré syndrome, but those cases aren't so occurring so often, and there's still studies needs to be done to confirm or reject this hypothesis of the correlation between Guillain-Barré syndrome and influenza vaccination. Diseases of bronchi and lungs, and I want to start from chronic obstructive pulmonary disease. And chronic obstructive pulmonary disease, it's a cluster of disorders. Some would say it's 3 disorders: asthma, chronic bronchitis, and emphysema. Others say chronic bronchitis and emphysema. So I would like to include here just 2 of the major causes or types, types, and it's chronic bronchitis and emphysema. We talked about asthma previously, and chronic bronchitis and emphysema, there is a strong linkage to cigarette smoking, and it's rather difficult to treat disease, and the improvement is rare or almost impossible. But when patient discontinues the behavior and behavior leading to development of COPD, still they can maintain the functioning of the pulmonary system on the level that was, they basically can, they can prevent the further deterioration of the pulmonary system if they start preventive measures, they stop the use of offending agents such as cigarettes. COPD is basically irreversible. At the same time, it's progressive. Tissue degeneration will occur, and at the same time airway obstruction. So the patient will not be able to independently work or function in general. Secondary to hypoxia and hypercapnia, which can result in respiratory failure. So one of the important points here that hypercapnia will lead in the pattern of breathing, or in the which is a consequence of shifting from normal CO2 breathing drive to oxygen related breathing drive. COPD of course can lead to cor pulmonale, right-sided heart failure, and other more rare diseases. Most significant factor again is cigarette smoking, but besides the cigarette smoking, inhalation of chemicals, pollutant, and may result in COPD. So when your patient presents with COPD, the smoking may not be the only or the factor that caused it. Smoking is again the most common cause. However, we don't see young people who smoke that develop symptoms of COPD, but compounding damaging effect may eventually develop, and around 60 years old people start having smoking problems. So it's difficult to do anti-smoking education, and I would use word propaganda, because just young people who smoke just don't believe it because they don't have any symptoms. And of course younger people may always say, this will never happen to me because I'm healthy and I'm smart and I'm like smoking good cigarettes, so I'm not smoking junk, I'm smoking quality cigarettes. But any cigarette can cause COPD, of course. And another type of COPD, familial type, alpha-1 antitrypsin deficiency, which you can really easily diagnose by doing a blood test for alpha-1 antitrypsin, can develop very early in 30s or 40s. So even if in the smoker the COPD develops this early, most likely the cause is familial, unfortunately. So chronic bronchitis, again, and emphysema can be the sources of this disorder, and can be present alone or together. Diagnostics can be done by histophysical chest x-ray may be showing. Pulmonary function tests may confirm the diagnosis, and ABGs will show the arterial blood gases composition for this disease. So the question is it emphysema or chronic bronchitis? If it's chronic bronchitis is an obstructive respiratory disorder when the inflammation of the bronchi, productive cough, and excessive mucus production occur. chronic bronchitis versus acute bronchitis. It's different in that chronic bronchitis is not caused by infection, and symptoms will develop and persist longer. Again, chronic bronchitis versus acute. Even I say acute is mostly viral, but in chronic bronchitis, this is nothing really related to bacterial or viral infection. It's an inflammatory response to cigarette smoking or other offending agents like chemical exposure, and inflammation will result in mucous glands will start developing hyperplasia, edema, mucus production will increase, bronchoconstriction, cough in defense against inhaled irritants. Of course, many of you heard that smokers cough, and it's like almost musical cough. I mean, there are no whizzes, but it's like this. You can tell just this is coming from cigarette smoking, and it's so sad that it's really, truly 100% preventable, and you still see people smoking on the streets. The health fad of 80s and 90s seems to be gone, and cigarette smoking getting back in vogue, I would say. So again, education of your patients is important. When all of this occurs, pulmonary defenses really die, especially our cilia. All the cilial waves are dying, and cilia dies, and phagocytosis decreases, and on the top of chronic bronchitis, respiratory infections will occur and start developing, and bacterial infections will be very, very common. Emphysema is an obstructive respiratory disorder that will result in the destruction of the alveoli or the alveolar walls, and it will lead to this huge permanently inflated alveoli. So lung tissue will remodel when it grows and will repair if inflammation occurs. Enzymes are involved in this process. They will be influencing or preventing the excessive tissue damage. So with the smoking, the enzyme deficiency may occur, and sometimes again people have familiar predisposition which will have the enzyme deficiency, which will cause enzyme deficiency. However, the smoking again, which initiates inflammation, will cause changes in enzyme levels and structural damages, structural changes. Emphysema will gradually affect the alveoli. They will start growing or developing into large, irregular pockets, and the pockets have huge holes in this. So all this leads that patient will start losing oxygen getting into the bloodstream. Elastin and surfactants keep the alveoli open and are slowly destroyed. So there is no elastin anymore, so alveoli will collapse during the expiration, and air will be trapped in the lungs. So the recoil, the main thing, the recoil is lost, and the hyperinflation of the alveoli will be narrowing the terminal bronchioles, and this all will lead to a distinct shape of the chest of the patient with COPD. So patients with COPD will often hyperventilate, and they will have this pink appearance to their skin, and the shallow breathing pattern, or hyperventilating breathing pattern with pink skin will lead to pink appearance, and will lead to puffing sound. So this is like a bad name to use, but to help you remember, the patient with emphysema will be called a pink puffer. And this is a picture that says that patients with emphysema and chronic bronchitis are using accessory muscles to help with the breathing and to make breathing more effective. So patient will develop barrel chest, and that's also significant finding, or physical examination finding, observational finding of the barrel chest in here. You can see that's emphysema because of the all the efforts to increase the oxygenation. Barrel chest will develop. And this is another picture that shows VQ scan, which will be here really revealing VQ mismatch. You see ventilation, how big it is, it's huge, and perfusion is normal. Yeah, so that's what causes mismatch. So if there's a VQ mismatch, it's a sign of like COPD. And this is typical patient with end stages of COPD, where patient already losing the reserves of fat, to everything is leading towards the development, towards the maintenance of oxygenation, maintenance of this high respiratory breathing rate, and patient will lose, will have this with typical appearance. At the same time, because of the compensatory mechanism, patients with COPD may develop the increased hemoglobin and hematocrit to compensate. Again, fast respiratory rate, and let's talk about the symptomatic treatment. Symptomatic treatment, bronchodilators, the usual albuterol, and I don't want to spend much time on this because that's the review of undergrad course. Mucolytics, which is gemfibrozil, most common, or Mucinex, cough suppressants, inhalers, and definitely avoidance of the exposure to the upper respiratory infection or any type of infection that can lead to exacerbation of COPD. Cough suppressants, again, is a good idea, quality of life. And mucolytics, you have to sometime to do a explanation and education of the patient, because patients think they don't have cough, but they have chronic bronchitis. They don't have cold, and they know they have COPD. So mucolytics, thanks to TV advertisements and Mucinex, consider this cold weather medicine, but people with COPD may need it year-round. Pneumonia is inflammation of bronchioles and alveoli, and it's caused by infection by bacteria, virus, or anything else. Any other pathogen can be to blame. So pneumonia may, as I said, have viral or bacterial character, and those two in diagnostics may have some notable differences. So pneumonia in viral case may lead to non-productive cough, but in bacterial case the cough will be productive. Viral pneumonia may result in low-grade fever when bacterial is higher, and viral pneumonia patients may have normal count of white blood cells. Bacterial will present with the left shift. And on X-ray, bacterial pneumonia, which classic pneumonia, will be presenting with infiltrates, and while we're looking at viral X-ray, there will be no or very minimal change. Of course, in viral case, you don't give antibiotics, but bacterial will be responding to antibiotics very well. And again, if the organism even isn't determined, certainly it's a good idea to go ahead and do some kind of sputum culture to determine what the causative organism is. So what happens in pneumonia pathophysiology wise, it may be a different origin based on the offending agent. For instance, if we have an aspiration pneumonia, the gastric content or tube feeding formula can reach lung tissue, and it will irritate and trigger inflammatory response. So inflammatory response from the aspirate will increase mucus production, and mucus production will lead to atelectasis and pneumonia development. And especially tube feeding has nice mixture of sugar, of protein, so it's a nice medium to grow bacteria. It's like Petri dish. So, and if pneumonia develops, the activities of daily living will become very difficult, and patient will not be able to move or even talk normally, and coughing will be very disabling for this patient. So if patient coughs and there is mucus production, again hydration becomes important. When we hydrate the patient, the secretion become very thin and easier to expel. So type of pneumonia you can call lobular pneumonia when one or more than one lobes involved. Bronchopneumonia is actually the most frequent type. It's a patchy pneumonia throughout several lobes. Interstitial pneumonia, it's very atypical, and it will occur in the areas between the alveoli, and interstitial pneumonia may caused by virus, and it's a sequela in influenza. Or interstitial pneumonia, and I'll finish right here talking about it, may be caused by uncommon bacteria such as Legionella, and Legionella is the famous disease that when it occurred first time was described at the American Legion conference, and then after that it was described very well, and the treatment is very well available. So nosocomial pneumonia is, of course, you know that it's a hospital-related pneumonia, and the contrasting type is community-acquired pneumonia. So unfortunately the situation is so bad with pneumonia in hospital setting, we even have special name for it, nosocomial versus community-acquired pneumonia. So again, treatment may vary depending what was causing the pneumonia. Tuberculosis is a very serious infectious disease, and that was in recent years declining the incidence. However, right now the incidence of TB is increasing globally, and tuberculosis treatment is really truly well developed. However, still many new cases detected every year, and the populations affected are maybe people who already have acquired immunodeficiency syndrome in underdeveloped countries. TB is still one of the major cause of illness, or maybe the major cause of illness as an infectious disease, of death, of illness worldwide. And I think the latest data would reveal from WHO, World Health Organization, that more than 2 million people may die from the disease every year. So how TB is transmitted? TB transmitted by infectious aerosol droplets. Patients will contract TB through the aerosol droplets. However, many people who are exposed to TB will not develop the disease because of the immune system. If you think about it, TB is very old disease. It's been described for centuries. However, it didn't lead to extinction of the human race, but still was affecting certain people. And it called consumption, it's consumed the body of the person. On the other hand, some people would be really healthy while taking care of the patient with TB without using any protective equipment. Or the difference is, again, is functioning immune system, nutritional status, and living condition. So the offending agent in TB is Mycobacterium tuberculosis, and it's a bacillus that still aerobic. It's not an anaerobe, it's an aerobe. And there is some resistance of Mycobacterium TB and to immune system. The bacillus can survive in the dried secretion or sputum, or let's say someone spit on the ground for several weeks. UV light, heating, alcohol, formaldehyde can be destroying the bacillus. And TB certainly can involve not only lungs but other organs like liver, brain, and bone tissue, bone marrow. There was a huge slide about it which I deleted. This is FYI information. TB, some would consider it opportunistic infection because it may become active in someone with, again, weak immune system. So if their immune system is weak, who will be affected? It will affect people with weak immune system, such as people who have acquired immunodeficiency syndrome, cancer, and or the immunodeficiency is not acquired but induced secondary to, let's say, organ transplant. Bad condition of living, again, poverty, homelessness, drug abuse, all of that increases TB acquisition. TB pathogenesis has two stages. When you think about it, there is a primary and secondary infections. Primary TB occurs when the bacillus enters the body And what happens, macrophages will surround, engulf the microbe, and they will cause local inflammation. And regardless on that, some of the bacilli will travel to lymph nodes, and type 4 hypersensitivity reaction will occur, and lymphocytes and macrophages will attack and form a granuloma. And what's a granuloma? It's really like a, I would say, a skin sac, or the correct way really to describe it, it's an epithelial nodule. So the granuloma will contain some bacilli, and some of them will be live. So they will form a tubercle. Tubercle is starting a caseous necrosis, and casein is like cheese, milk related. So tubercles will have inside, in the middle, a stuffing of this cottage cheese like material, which is basically caseous necrosis. And so it will be like a little ball stuffed with it. So immune system will be hindering that development. So even with the TB exposure, the lesions, the little balls, will be still staying small. And the better news, even, that they are not only small, but the fibrous tissue will grow around it, and even to make the shield even better, the calcification will occur. So all this described as a gone complex. So this prevents bacilli from jumping out and running around the city and exposing other people. So the bacilli can remain dormant for years and centuries as long as the immune system does well, you know. But let's think if something happened and the immune system is not intact anymore, and then TB will jump into secondary or active phase. So in this phase, TB can break through the gone complex and spread through the lungs to other organs. And this when, again, active TB starts. What happened in this case, patient will develop cough, and what even worse, hemoptysis. Patient may have night sweats, fever, chills, anorexia, constitutional symptoms such as fatigue, again, anorexia, fevers, and depending where the TB develops, then it will be developing symptoms related to the organs. So diagnostically, Mantoux test, and you all had it because you are in these programs. And if Mantoux test is developed and it's positive, then chest x-ray may be performed and sputum culture. So you all been through this reading many times, so I won't be emphasizing it too much. But let's talk about treatment. TB can be successfully treated outpatient, but unfortunate part of it is that the therapy is certainly very long duration. 6 to 9 months, can even take a year, and it's combination therapy of many different drugs, and maybe resistance to antibiotic or antituberculin medication develop. The good news is that if your patient develops TB, the medication will be provided free of charge by public health service, and some states even have laws that the non-compliance with therapy may be considered unlawful and result in putting someone into jail and forcefully making them take TB drugs. But again, prevention of transmission is mostly affects the healthcare providers. TB approved masks, adequate ventilation. Of course, patients should be in negative pressure rooms when they are in the hospitals, and absolutely the contacts, everything has to be monitored by infectious disease service in the hospital. So this is a serious condition, but it's treatable and preventable. And again, the good news is if your immune system is healthy, if you even exposed to the disease, you may not even develop the disease without. And by you may not even develop the disease, you may not have gone complexes, and even if afterwards you are immunocompromised, the disease will not develop. But again, if you are taking care of a patient with TB, and as practicing nurses or nurse educators, you may encounter these conditions, please take personal protective equipment, and please tell the same to your students.